Thank you everyone for coming here today, either in person or joining us online. So I'm really pleased to see all of you here. My name is Gloria Wong from the Department of Social Work and Social Administration at the University of Hong Kong. And today we are very excited to have this Faculty of Social Science, Health and Population series on the topic of Hong Kong and global responses to dementia. And I want to mention just a few things. So we actually did the publicity quite late, but despite having a short notice, actually we have over 200 people signing up for the symposium. So actually it says how important the topic is, despite we have gone through a period of COVID and currently communicative disease seems to be having a less priority, but it's not the case. Dementia is still very high on the priority in our health and care system. So without further ado, may I invite our Dean of Faculty of Social Science, Professor Ming Wang, to give us an opening remark. Professor Wang.
Okay, hello. Hello, everybody. Good afternoon. So my name is Ming Wen. I'm the Dean of Social Sciences at Hong Kong U. I actually just joined Hong Kong U maybe 4.5 months ago. And I found that there are so many very exciting research activities ongoing, including the one we're going to talk about today. It's my great pleasure to give some opening remarks for this wonderful hybrid symposium on dementia. And this is such an important topic we're facing today. So dementia is a health and a social care priority globally, especially in the Chinese communities. In 2021, UN Decade of Healthy Aging started. This is a global collaboration to promote healthy aging and aiming to compress morbidity and disability in later life and enhance healthy life expectancy. Obviously, cognitive health, staying free from dementia is clearly an important component of healthy aging, directly increasing the likelihood of independent living among older adults. In fact, dementia is currently the 7th leading cause of death among all diseases, and one of the major causes of disability and dependency among older people worldwide. It is estimated that currently about 55 million people worldwide living with dementia. And as an age-related condition, it affects aging and aged populations in particular, but also their family members. It is one of the most expensive public health problems of our time. By 2030, the global prevalence of dementia is estimated to reach 75 million, costing over $2 trillion worldwide. And Chinese populations are among the major drive in the continued growth in global dementia prevalence. Earlier studies estimated that there are approximately 9.5 million Chinese people living with dementia, and this figure includes Hong Kong. And this number is still rapidly increasing. So how do Chinese societies respond to this huge burden in an equitable and sustainable way will have massive impact, and not only on the numerous affected families, but also on global economy on the whole. So this symposium is very timely, providing a precious and exciting opportunity for us to hear from Professor Huali Wang from the Peking University Institute of Mental Health, the person driving China's Dementia Action Plan, to share with us the latest developments in dementia policy in China. And from Martin Knapp from London School of Economics and Political Science, who has authored a World Alzheimer's report on task shifting and led 7 low and middle income countries to develop their national dementia strategies. And also from our own TIP-CARD team on their 3 years of research efforts in using multiple social sciences research methods to inform dementia policy in Hong Kong and other Chinese communities. So TIPCARD stands for Tools to Inform Policy, Chinese Communities Action in Response to Dementia, TIPCARD. So this project, please allow me to say a little bit more about this project. So this project is led by Dr. Gloria Wong, you just saw, Dr. Huali, and Professor Terry Long from the Department of Social Work and Social Administration in the Faculty of Social Sciences at Hong Kong U, together with an interdisciplinary team, including the nursing school from Hong Kong U and other partners. This project illustrates how social sciences research can have real-world impacts. This project is funded when the Hong Kong government's Research Grants Council first launched the Research Impact Fund, RIF. So RIF promotes research that delivers benefits to the wider community, emphasizing impactful and translational research projects, and encourages collaborative research beyond academia, for example, with government departments and the industry. In dementia and many other population and health-related topics, we really need a shift of balance from a narrower focus on drugs and biomedical research. Those remain to be very, very important for treating, curing, therapeutic values, but we need a shift from them to developing research evidence that helps ensure good quality care and a better quality of life, which often lead to more sustainable and also economically justifiable strategies. So in today's symposium and the research seminars by TIPCARD researchers, this and next week, we will learn about the use of a wide variety of research methods to shape population and health research, collect evidence information, and including information collation, such as systematic review with network analysis, electronic health record studies, stakeholders consultation, Delphi studies, economic analysis, and capacity building to empower stakeholders to make use of available information. So I hope all of you are already agreeing, or at least feeling more convinced by the end of this symposium, that population and health research would be much more impactful when social scientists are actively involved in interdisciplinary research teams. And we truly look forward to further collaboration building on this network. And with that, thank you so much. And, the floor is yours.
Thank you so much, Professor. That perfect stage for us to kick off the symposium. I will just have a few slides to share with you about the TIPCARD project, which is the reason why we are here. So as Professor Wang mentioned, the reason why we are hosting this symposium is exactly that we want to have research that have direct real-world relevance and implication. And TIPCARD is exactly this kind of project, we hope, and we want to share our research findings so that it can have real influence on policy related to dementia. What you see here is actually one of the infographic we prepared at the beginning of the project, hopefully to translate information into easily accessible information tools that our public, our service provider, our policymakers can make use of. Now, the project, it was a 3 years project, and we're trying to squeeze everything into 1.5 hours, so that's almost a task impossible. But a lot of information we have already put on our online platform, as well as we have been sharing throughout the past few years. So the reason is that we hope to build capacity in the local community in planning and implementing equitable and sustainable strategies in dementia care, and to provide accessible tools. So these include data, local guidelines that are co-developed by our stakeholders, and also to generate policy solution for Hong Kong. So we'll hear much more about the project later on today from our speakers, but I just want to very quickly summarize what we have already shared in our previous symposium and also in our previous seminars. So first of all, we want to understand what Hong Kong stakeholders want in terms of dementia care. So we asked over 200 stakeholders what they think dementia care should look like in Hong Kong. So we engage different people from different disciplines, different sectors. And then because of that collaboration work, we have been able to develop well, you can't see the details, but we have a draft plan for Hong Kong, a roadmap, if you like, for dementia care in the next 10 years. And although you won't be able to see the details, two key points from this public stakeholders engagement. So we do have a common goal, or actually two common goals to achieve. So the first is that all our stakeholders, no matter they are coming from a health background, a social care background, a user background, we agree that the goal that we should be targeting is to make Hong Kong a dementia-friendly city. And by that, we mean that people living and their carers can lead normal life and meaningful life, and living with dignity and meaning and good quality of life, and they can age in place. And the second goal that we agree is that perhaps through preventive strategies, we could have a stabilized number of people living with dementia. So hopefully we can, through some public health measurements and education measurement, that we can reduce the number of people living with dementia and the incidence rates. So some of these work have already been published, and we will keep sharing the information through papers and other means. Another key question we want to understand is what intervention works in Chinese population. We actually had a seminar a few days ago to see. So most of the information we have in terms of intervention and support for people with dementia come from Western countries, Western literature. And when we set up this task to review all papers, publication in Chinese, we thought was a small piece of work. But then when we start looking into paper published in Chinese, we find out that actually the amount of paper is huge. So several tens of thousands of papers we have screened, and then coming up with more than 500 papers published about interventions and care for people living with dementia in China, in Chinese population. And I wouldn't repeat the findings that we shared a few days ago, because we actually will upload the whole seminar online. So if you're interested, you can go to our website to learn about the details. But just very quickly to show you, actually there have been a lot of different various type of intervention that has been trialed in Chinese population, including traditional Chinese medicine, including non-pharmacological intervention. And because of the complexity, we have been trying to use network analysis to see what is the comparison. So the simple message here is that actually any intervention works better than usual care, which is a good news. But another important information is that actually the research in Chinese population is still developing. The quality we can still improve a lot, and with more evidence, actually we can provide better information to support policy development. So that's a slide I've stolen from Dr. Darrell and also Dr. Cheng. So they are leading this huge meta-analysis work. And finally, I will finish up here. So we want to know what is the current situation of dementia care in Hong Kong, and also what is the cost, because when we want to plan policy, we need to understand whether it is affordable and what is the most cost-effective way to deliver those policy interventions. So we have been doing a lot of analysis, including this. You won't be able to see the details, but this is one example of an analysis done by our PhD student, Lingnan, who actually look into data from hospital authority to see how would multi-morbidity, so people living with dementia as well as other long-term condition, affect the healthcare cost. And by the calculation, actually, we see that the healthcare cost is actually quite anomalous. And later today, we will hear more. So this is just healthcare, but actually we know that the informal care and also social care cost is also a major part of the cost. So with these estimation, it will help us to develop more informed strategies. So we'll hear a lot more from Tipcart later on today and also after today. But I want to stop here because I hope to be able to share with you a lot of exciting work that we're doing, and we hope that our team actually has grown over the years, and hopefully this will be an invitation for interested researchers to join us in delivering research results that can have a real world impact. Okay, so thank you so much. And I know that time is actually very tight today, so I would like to end my part here. And may I invite our next speaker, Professor Huali Wang, to share with us the updates on China's Dementia Action Plan.
Gloria, can you see my screen?
Yes, perfect.
Okay, thank you very much. Yeah, good afternoon, everybody. Thank you very much, Gloria. Thank you for inviting me to be here. I'm sorry that I cannot be there in person, but it's my great honor to present on this seminar. I'm very excited, especially after I learn more about you from you about the TIP project. It is great. Although we have not done so much systematic work to find more evidence for dementia care plan, but I think that your project may help us to build more evidence in the future. So I think that today here I would like to share some of my perspectives on the development and the implementation of China Dementia Plan. And before I start my presentation, I also would like to thank Emily, Maggie, and also Hong Kong U team for coordinating my participation in this event. I know it is a great challenge for you to coordinate such a hybrid conference. Thank you very much. Today, my presentation will have 3 parts. First, I will still briefly review the dementia burden here in China, and also share some of the policy response to dementia challenges in the past decades. And also, I will share some of the existing challenges against quality care for dementia, so that we can have more ideas about why we need a dementia strategic plan and how we need to promote the implementation of the care plan. And then the second part, I will share some of the local practice that help us to address dementia burden here in recent years. And the last part is the most important part. I will review the National Dementia Strategic Plan and also relevant policy documents that help us to improve dementia care and research. And in this part, I will highlight some of the recent progresses in implementing the plan. First, I will briefly review the background of developing the dementia plan. We all understand that the population in China is aging dramatically. According to the 7th population census, people aged 60 and above have reached up more than 260 million, accounting for more than 18% of the whole population. So aging is not only a social issue, but actually it is also a public health concern. One of the significant health problems for old adults is dementia and related cognitive impairment. As myself as a geriatric psychiatrist, I have been seeing more and more people seeking for professional help for their cognitive problems. Some are in mild stage, but some are in advanced stage. So the issue is a great challenge in our society. According to a most recent epidemiological study led by Professor Jia, they estimated that there are approximately 50 million people living with dementia. It is also projected that the prevalence of dementia will continue rising in the next decade if there's no effective prevention strategy, and also if there are no true early intervention approaches. So tackling the challenges of dementia has been prioritized in our National Healthy Aging Agenda. Just now, Professor Wang mentioned that promoting healthy aging is a universal task worldwide. Still here in China, we have to acknowledge healthy aging. Promoting healthy aging is one of the most important work for us to prevent more and more old adults' health problems. Although we realize that dementia is a great challenge, what we have done before, actually, if we went back to 1999, that's about nearly 25 years ago, the WHO Director General at that time, Dr. Brundtland, addressed aging and dementia would become one of the major mental health issues at the WHO China Mental Health Awareness Raising event. Her speech at that time immediately brought dementia into the national policymakers' mind. And then in the following decades, several national mental health plans, China Aging Developmental Plan, and also national research funding bodies have started to include dementia in the policy articles and the research agenda. And from 2013 to 2019, more and more policy documents have been formulated. They addressed concerns related to dementia, not as a single document, but put dementia in some of the articles. For example, the 13th five-year health aging plan called up attention to popularize appropriate techniques for dementia care services. Now we have been in the 14th five-year plan. Dementia is also one of the priorities for healthy aging. So I will update it in my third part presentation. Although policy documents have been addressing dementia in a critical way, however, there remains several challenges that against us provide optimal dementia care. I think that the most important barrier is the resources for continuous care is still insufficient. In the year of 2020, Alzheimer's Disease Chinese conducted a survey among families of Alzheimer's disease, and we completed a national report. In this report, we observed that the rate of seeking a diagnosis for dementia was very low. About 1/4 of the respondents had to visit specialists in other provinces or cities. That means the care services may not be available in their residence area. Also, we found that regular follow-up visits were not provided or guaranteed. Nearly 1/4 of respondents had never been followed up, even after they have been diagnosed with dementia. And the second challenge is the service and the support actually are still fragmented. In 2021, we did a survey among 143 teams who have claimed that they are providing psychosocial support for old adults and those with dementia. And when we explored the types and frequencies of their services, we found that the service for dementia was very limited. Most often, these teams only provide cognitive training, but they did not provide post-screening support. Even the diagnosis was seldom provided. So that means many people have not been cared timely. And the third challenge is actually in big cities, still we have developed some services, and now we have extended the memory clinics locally, but still many of the families did not use service adequately. In rural areas, the situation is more critical. More than 60% of the persons did not receive dementia-appropriate medications. Although currently there are no effective disease treatment or disease medication, but actually some of the medication can help to maintain the status or help to prolong the disease duration. But the persons have not used these medications yet. And also the external care resources were not adequately accessed. Most families remained to only rely on home care, like the nursing homes, institutional care. They have never been thought of. They consider that this institutional care or nursing facilities are only their final resort. They did not understand the service in the facilities has been raised to a high quality. So these are the three major challenges that I have identified. So we think that it is crucial to develop a dementia plan that can help us to coordinate different services and resources and help to promote appropriate dementia care service and improve access to the services in China. Actually, in the past decade, scholars, social workers, healthcare professionals have put a lot of efforts to explore potentially cultural sensitive dementia care model. So in my second part, I would like to present some of the collective experiences from local practice. The common elements actually of the service model in big cities like Beijing, Shanghai, Guangzhou, and Chengdu is the adoption of a whole of society approach that are probably similar to other chronic disease prevention. And actually in this framework, people living with dementia is the core of the service circle. And to achieve the goal of maintaining the person's functional ability, relevant stakeholders have to be mobilized. For example, family members are supported and empowered. And this part of work has been promoted in big cities, but has not been outreached too much in underrepresented areas. And the community function is maximized to build friendliness. We have also tried some of the models that to promote dementia-friendly communities in some cities, but it has not been promoted nationwide. And some of other different sectors, we encourage them to collaborate so that it can help us to minimize the fragmentation of the services. So in recent years, the concept of continuous care has become well accepted by different stakeholders. We can hear more and more terms of continuous care in different meetings, different settings. And what are the continuum of dementia care? We summarize it into 4 consecutive steps. First, providing health education and screening in community that can help us to identify risk population and to reduce the major risk factors. And the second, we have to conduct a comprehensive assessment help us to making timely diagnosis and develop individualized care plan in memory clinics. So that can help us to minimize the gap for post-screening support. And third, we integrate pharmacological intervention and the non-pharmacological treatment as a post-diagnostic support. In this part of work, we try to mingle the medical health professionals with social workers. So that is why in the past decades, we have been working with many social work teams and also collaborate with social scientists to promote post-diagnostic support. And last but not least, is we have to empower and support family caregivers that to help them to reduce the burden. And in this long journey of caring for people living with dementia, post-diagnostic care is most important. For myself, I have I started the caregiver support group. This is the first one in China. And we realized that even the monthly gathering can help many family members to be supported. And also they feel that their burden can be reduced. And then we examined the feasibility and effectiveness of memory health in community. We found that specialist community collaborative management could increase the level of dementia knowledge among old adults and among community health workers. Also, this can help to improve the rate of cognitive screening in community health centers, and that help facilitate the access to cognitive training for persons with cognitive impairment in their communities. This is one of the services that support the aging in place. So in the past decades, we did a lot of pilot studies and explorations, and we reached a consensus that this collaboration should be built between specialist memory clinics and the community health centers. This can help us to facilitate providing continuous dementia care. For example, in such kind of collaboration model, community can take more responsibility for health education, cognitive screening, care support, and also follow-up visits. While specialists can take more responsibility for like community referrals, provide assessment, and even some special examinations to make a timely diagnosis, and the support to develop a care plan and supervise the community follow-up visits. So part of our experiences have been introduced to WHO West Pacific Regional Office, and some of the experiences have been included in the toolbox. This toolkit could be accessible from the WHO website. Based on these experiences and some of the local practice, many of the societies have tried every effort to advocate for developing national dementia plan. Unfortunately, in 2020, the General Office of the National Health Commission issued a work plan for exploring dementia prevention and care services. And this plan was enacted as part of the broader Healthy China Action Plan. The Healthy China Action Plan is schemed between 2019 to 2030. The full name is Campaign to Prevent Disease and Promote Health. And the action plan established the goal of reducing the growth rate of dementia in people aged 60 and above. As Gloria just mentioned that, we have tried to stabilize the number of people living with dementia. So one of the Healthy China Action Plan has included this in the plan. They call up the public health initiative to address the common risk factors and the screening and monitoring to support early interventions. So like healthy diet, exercise action plan, that could supplement the dementia risk factor prevention. And this dementia strategic plan actually is built on some of the previous efforts that help us to address dementia awareness, diagnosis, and care. As this is one of the first strategic plan, this special work plan represents I consider it's an important step forward that help us to move the dementia policy forward. And this plan targets several important areas. Some are the work for people living with dementia. Some are supporting capacity building that can help us to train more and more people to be involved providing dementia care services. And during this period, some research bodies have also funded a lot of projects that help us to address the issue related to dementia. For example, the China's Ministry of Science and Technology have funded a number of research projects relevant to identify early markers for the biomarkers for early dementia diagnosis and help us to address the risk factors of dementia. In 2021, Ministry of Science and Technology have launched China Brain Project. It's called Science and Technology Innovation 2030. This project has been officially launched, and within this project scheme, we have started to build clinical and community cohort studies that can help us to explore early diagnosis and intervention for dementia. So myself is one of the project leaders for clinical cohort. So that's why now in recent days, I'm visiting the fields that are involved in clinical cohort to help them to improve their clinical capacity so that I cannot be in Hong Kong. And in addition to such efforts, our National Health Commission also tried to help to improve the clinical practice. So in 2020, the Health Commission, National Health Commission published a clinical practice guideline for mental disorders, and dementia is included as one of the chapters. Within this guideline, actually, to provide a comprehensive integrated care, including not only pharmacological intervention, but also care for the people living with dementia has been included. And also the guideline addressed that trying to reduce the risk factors and getting the person living with dementia involved in the society is important. So I think that all these guidelines help us to address and also help us address the concerns with dementia and also help us to promote dementia care in different areas. And also in there are some other policy sectors, for example, like the medical insurance and also social welfares. They have launched not only the medication reimbursement care plan, but also launched some national campaigns to increase public awareness. So all these efforts have paved our way forward to promote dementia care. But in the past years, we did some interview to identify what are the difficulties to implement such strategic plan. And we identified several major barriers. The first barrier is the readiness to provide dementia care in community is still very low because the level of dementia knowledge is not high enough. And the person, the administrative staff in the community, they did not recognize the appropriateness of providing dementia care in neighborhood. And sometimes they are not ready to accept community dementia care projects. And the second, the workforce is limited. the number of well-trained multidisciplinary service team is very small. As I mentioned before, the survey, the more than 140 teams I surveyed, they claim they provide services, but they are not capable of providing coordinating services from different channels. So also like the screening rate has been improved, but the post-screening support has not been developed accordingly. And the last barrier is there has not been sustainable financial mechanism to support the implementations. For example, although the government has launched the dementia strategic plan, but there's no national funds that could guarantee the implementation everywhere. So now the funding for dementia care services are mostly rely on the local economic support. So that depends on the local economic status and also their local financial investment and the number of their local financial investment. So these barriers actually have been against the implementation of the National Dementia Plan. So in the past, although in the past 3 years, we have been challenged by COVID-19, but we still spend some efforts to support dementia care plan. Although some of the work had to be done online, but we did some trial. So last year, the National Mental Health Centers supported an initiative implementing social prescribing for improving dementia care. So in this project, services linkers is very important. So last year, we trained a large group of service linkers that can coordinate medical professionals and social workers and also psychosocial intervention staff in the community. And now we started to collaborate with Tencent to develop a digital triage platform that can help us to improve the efficiency of coordinating the field work so that the social workers, medical professionals, and the link workers can identify the care needs through the digital technology. And also they can coordinate their services through this digital platform. This year, we are going to start a trial that help us to address whether such kind of digital triage platform can facilitate effectively of their local service. And just 2 weeks ago, we had a meeting with National Health Commission officers, and we got the news that this year we have confirmed the protocol to implement National Dementia Plan. We set 4 major projects for this year. First, raising awareness. We have done before, but this year we have to coordinate all the efforts to raise awareness and help the public to understand the dementia. And importantly, we need to train other stakeholders like public transportation workers, police, and other aged service related officers to understand the dementia. And second, we will try to incorporate cognitive screening with annual physical checkup for old adults, and then guide individualized care for each person. And third, this year we will put more efforts to provide post-diagnostic support. Now it is more ready than before because we have trained more and more service providers, as long as we can help them to integrate with medical and social workers. And lastly, we still need to scale up capacity building for service team that can implement more approaches with social prescribing. So we anticipate that this year we will reach more than 100 communities or villages to make the care available for those affected with cognitive impairment. So I hope that after this year's implementation, we can gain more field stories and field experiences and also research evidence to share with our colleagues today. So this are my presentation keynotes. In summary, dementia is common. Caring for persons living with dementia is challenging, but if we use the whole of society approach, that may help us to improve the access to dementia care. So according to our previous experiences, mental health in community projects have demonstrated its feasibility and effectiveness in some part. So we can continue with such kind of work. And the last, improving dementia care has been prioritized in the health aging agenda. The National Dementia Care Strategic Plan has provided policy support, but we still need to build more society readiness, workforce availability and capacity. And also we hope that we can seek more financial mechanism to support the work and implementation. But I still consider that we need to do more research. So we hope that we can learn from Hong Kong to build more evidence for policy implementation. Our work has been supported not only by civil societies, but also by charity foundations. We hope that next time we can gain more experiences and share with you for more details. So thank you very much. Thank you, Gloria, for inviting the session. I will be online and hope that I can join discussion later. Thank you.
Thank you so much, Dr. Wang. And that we can invite you next year to Hong Kong in person to share more. So in fact, actually, that has been a very exciting development because I remember just 2 years ago, we had invited Professor Wang to share with us the newly developed China Dementia Action Plan. And in a few years' time, actually, a lot has developed. And in fact, 2 years ago, we on the same occasion, we have Professor Knapp sharing with us the international development in terms of dementia policy and also his work in 7 lower and middle income countries. So may I invite Professor Knapp to share with us his updates on the global context. So Professor Knapp.
Thank you. You did everything for me. That's very kind. Okay, so great to be here. Lovely. Thank you very much for the introduction. And I'm very pleased to be here to hear some of the tip card results. What I'm going to talk about today is the global context. And what we've heard, very rich presentation just now on the detail and work going on in China. And what I'm going to do is always step back a bit to look at the global context and the global challenges and some of the responses that we're seeing, particularly coming from the World Health Organization. And then I'll talk about the STRIDE project, which, as Gloria mentioned earlier, we've been doing. We sort of finished it, but we haven't finished writing up all the papers. Been working on that in 7 low and middle income countries. So firstly, about the population change, we've got this change in population. I've just highlighted 2 of the countries on there, China and UK. And one of the things that's going to be really important when we think about the response to dementia, which is hinted at on that slide, and I'll show you in more graphic detail in a moment, is the speed of change. So you can see the speed of change, the growth, the line for China, for example, the red line going up quite rapidly compared to, for example, the blue line for the UK. And it's that rapidity of change, which is particularly challenging when we think about responding to a condition which is so highly associated with aging, such as dementia. And then associated with that is this global picture of dementia prevalence. On the left-hand side, it's the age-adjusted prevalence. Perhaps the more helpful one for these purposes is on the right-hand side. That's the total number of people living with dementia that are anticipated to be living with dementia, I should say, between 1990 and 2050. And this is a paper published just last year in one of the Lancet journals. So what you can see is a very rapid growth. This is the global picture in terms of dementia prevalence. And the question then is, how prepared are we as a society or as countries and communities and families and individuals to respond to what is going to be quite a substantial challenge? It's particularly a challenge in certain parts of the world. So again, this is from that paper from last year, a very, very detailed, lovely, beautiful map, lots of lovely colors. But the colors, the dark red colors, are the ones which indicate the highest rate of expected change in dementia prevalence. The dark blue is the lowest percentage change. So even countries like the United States and parts of Europe, including the UK, are expecting a growth of between 20 and 40%, and we're alarmed about that. We're worried about how we can manage that to respond to that. In some parts of the world, we're going to see a growth of nearly 2,000% in the number of people living with dementia over the period to 2050. So this is very, very rapid growth in certain parts of the world. Then that takes me back to what I said earlier, and this is the key thing that we need to remember. This is not my slide, or it is my slide, but I copied it from somebody else. This is pointing to the rapidity, the speed of change, and it tells you how long it takes a country, or has taken a country, to go from 10% of the population aged 60 or above to 20% of the population. And what you can see is a country like France, over here on the left-hand side, it's taken from 1850 to about 1980, that population aged 60 and above to double. Now, France is one of the countries in that period which had lots of wars, lots of deaths from wars, as well as there being diseases and so on, which has helped to slow down that aging population. But countries like China and Brazil and India, on the right of that slide, have got a very, very rapid growth in that aging population. As I say, that is particularly a challenge. So then there are many challenges, and I think they are often associated with that speed of aging change. Now, the two reports there on the slide, the top one is the WHO report, the Global Status Report on Public Health Response to Dementia, which followed on from the Global Action Plan, which I'll talk about a bit later on. Huali Wang mentioned the WHO action in this area. The bottom one is the World Alzheimer Report. The Alzheimer's Disease International publish a report every year. And in 2019, they focused particularly on attitudes to dementia, awareness, stigma, discrimination, and so on. And that is, I think, one of the huge challenges we face. There's just a poor understanding of dementia, so lack of awareness, lack of understanding of what it really means. Many people still think of dementia as just a sort of rather gentle, mild worsening of memory. And yes, there is that cognitive decline in memory, but there are many other things that are associated with dementia, including anxiety and agitation and aggression and some personality changes and so on, which make it very, very challenging. So firstly is that lack of awareness, and that has often led to abuse and neglect and discrimination in various forms. Secondly, we've got this lack of preparedness, this unpreparedness of health systems, the sorts of things that Huali Wang was talking about, with workforce not being there, awareness, understanding not being there, and so on. Those health systems, those care systems, housing systems are not prepared for what is going to be happening. And we've also missed opportunities to reduce the risk, which is another one of the things I'll come back to. There's the underdevelopment of care systems. It's still the case across the world that it's mainly women who provide the unpaid care for people across with different health conditions, but especially of dementia. And we've seen a growth in many countries now, very rapid growth of private sector services, which are often unregulated and of very variable quality. In many countries, there's competition, I called it, from other health challenges, contagious diseases, COVID, obviously, HIV, malaria, various other conditions which kill people. And it's still thought that dementia doesn't kill people in quite the same dramatic way, if I use that horrible language. But there is that competition for resources, for workforce, and so on, which needs to be faced up to. And then the issue, going back to family care, unsupported family care is unsustainable in modern economies. So I mentioned then WHO put out this global action plan in 2017 for a period of 30 or so years. No, not 30 years, fewer than that. I will correct my maths, but about 8 years. Earlier, their mental health plan is longer. That's why I'm getting confused. These are the components of that. These are the areas that they emphasize that countries need to pay attention to. So first of all, make this a health priority. They talk about public health priority, which has two meanings. It means health priority for the public or for the public sector, as well as a public health priority in terms of prevention, which comes further down. So it's a priority for the public response to health conditions. It's dementia awareness and dementia friendliness, which we've heard about a bit already, and we'll hear about a bit more in relation to tip card. It's about reducing the risk, and there are many risk factors which we now know are associated with later development of dementia. It's then improving diagnosis, which remains pretty awful across most countries, treatment where we can find it, care and support. It's supporting unpaid family carers, friends, communities that provide that support outside the formal health and care systems. It's about information systems. So getting the information together so that we can understand what's happening in people's lives, what's happening in services, what's happening, as Huali mentioned, in relation to funding. And then it's investing in research and innovation. I will skip this in the interest of time, except to say that there are then countries, I think it's about, ADI I think is about 40 or 50 countries with a national development plan. I think WHO I think is about 40 or 50. I think the ADI I think is rather smaller than that in terms of anything really meaningful. But in places like England, some of the high-income countries have been able to put together these plans. And this just lists the things that are given as priorities in that. This is more the clinical end of things, but in that response to the dementia challenge. So let me then finish up with a few slides on the project that we've been running for a while called STRIDE, which is strengthening responses to dementia in developing countries, in a range of different countries. And the 7 countries that were core to this project are the ones in the slide there: Brazil, India, Indonesia, Jamaica, Kenya, Mexico, and South Africa. And on the map there are the countries in the dark red. There are also some other countries on there which were associated with STRIDE, and Hong Kong is in there if I can just about see it. And I now realize I've got my slide is wrong, because we now have a STRIDE project in England, and I've managed to not put that onto the slide. But so we've got these countries that were either signing up to the full project, those 7, or other countries doing components of STRIDE, and TipCard is one of those relations of STRIDE, which we'll hear more about in a moment. So the purpose then is to build capacity in generating and using research evidence. So what we did was invest in researchers, in developing research skills across those countries so that we could then improve dementia care, treatment and support. So it's investing in those ways. And I'll show you some of the things that we did. I won't leave this slide on the screen for very long, just to say, wow, look at all those names. Imagine the fun we had in coordinating all these people, but lots of organizations, universities, NGOs, and policy bodies and so on. So what we did in the STRIDE project initially was to have these theory of change workshops. I'm a very big believer in these kind of implementation science mechanisms, and this is one of those, a theory of change workshop. So it's an intensive discussion with a wide range of stakeholders in each country. We start off with one centrally to identify what needs to change and why. And in some countries, we had officials from the ministry who were responsible for dementia policy or dementia practice, who had never previously met anyone living with dementia. This was the first time they'd done that. So it's getting people together with a range of different experiences and areas of expertise to talk about, okay, what do we need to do? Why do we need to do it? And how can we perhaps begin to move towards achieving those objectives? So then what the project did was to work across the 6 countries. There were 7 countries, and there were 6 things that they each did. And I'll just put these up on the slide to begin with. So they coordinated their priorities. They did this theory of change. They did some qualitative research to understand attitudes to dementia. So not big surveys, you couldn't do that in the time we had available, but trying to understand the local issues, whether dementia is still considered to be witchcraft, as it was in one of the African countries, for example, how people understand it. Then to analyze what we call the dementia situation, the political economy. Where does dementia sit in the policy landscape? What are the resources that are there in health and care systems and so on? The fourth component was to do these case vignettes. So we described vignettes of people living with dementia being supported to try and understand how those we responded to and what the roles were of different providers. We did systematic reviews of prevalence of dementia in the 7 countries, and I'll show you one thing on that in a moment. And then we did some work to look at capacity building, supporting advocacy bodies like NGOs to help in developing the evidence base and the implementation of it. And then the 7 countries could choose what they did. And this is where we got these much more perhaps conventional research activities. So in 3 of the countries, they did a qualitative study of the costs and impacts on families, providing care for people with dementia. You can imagine, by the way, that all of these activities were hugely impacted by COVID. So if you're trying to do studies which are interviewing carers who are in quite precarious situations sometimes, and you've got to switch to some kind of online engagement with them or telephone engagement, that made the research quite challenging. But that's been really rich in understanding how carers, family and other carers, can provide that kind of support in very, very different cultural and economic and social contexts. The second one was 2 countries chose to focus on how to tackle stigma, and I'll show you a toolkit that came out from that project. 2 countries then did work to collect data from households. Again, the COVID impact was pretty horrendous in this case, and we ended up doing these surveys right at the end of our funded period. But I'm delighted to say we did these first ever surveys in households in these 2 countries to understand a whole range of things about living with dementia. And then we're doing some work on the costs of care, which is not in all of the countries, some of the countries, depending on the data. So lots has been done and lots has been published. That's just a little slide I put together about 3 hours ago to show you some of the papers and reports. It might even have been 2 hours ago. It's very, very last minute. If you go to the website for Stride, you can get more detail. And we've got 2 special issues of journals coming out this year. One is dementia. One is the International Journal of Geriatric Psychiatry, which will have collections of papers from the project. And then just one example of some of the more sort of grounded responses, grounded activities from the project. This is a new anti-stigma toolkit, which develops particularly from those detailed projects in Brazil and Kenya, but also from the learning in the other 5 countries. So all of them contributed to this. And it's a toolkit to try to address this endemic, pervasive problem of people not understanding dementia and often being very discriminating and negative about it. Okay, in summary, then, what needs to happen? Well, to state the blindingly obvious, across the world, people are living longer. And I think before we say anything about the challenges of dementia, we should say, well done to the world for letting people live that longer, for making that possible. And old age brings lots of joys, but it brings challenges. And one of those big ones is dementia. So it's a major health challenge. And as we've seen from presentations already, and we'll hear more from Tipcard colleagues and others, it's a major economic and social challenge as well. And it's an even bigger challenge for the future than it is today, especially in lower middle income settings across the world. That means the responses need to be of many kinds. They need to be global. So WHO playing a global lead in trying to help countries to develop the appropriate plans and policies and practices. It needs national coordination, it needs local implementation, and it means individual responsibility. One thing I always say in the UK is, when I was a kid, I probably never met anybody with dementia. Now, children today, everyone in the UK knows at least one person with dementia, because people live longer, people are not hidden away in institutions, they live in the community. So we understand what dementia is. Individually, we need to respond to that appropriately. But I think those responses have generally been slow. Then I think projects such as Stride and Tipcard can help. They highlight gaps. they generate new evidence, they support action, they can inform policy discussion. But what we have to remember is even with wonderful, beautiful global, national, local plans, we need to turn those policy intentions into properly resourced actions. And I will finish with that. Thank you very much.
Thank you so much, Professor. And maybe you can stay on the stage because now we have a few minutes of discussion. So may I invite Professor Terry Lam from the Department of Social Work and Social Administration and Professor Doris Yu from the School of Nursing from Hong Kong U and Huali, I hope you can join us online. So I understand that actually we are overrunning a little bit, but actually we have a lot to discuss. So may I propose that we finish the this session a little bit late. So we'll have our break 4:10. All right, so let me pass the time to Terry, Doris, Martin, and Huali.
Testing. You can hear me, right? The microphone. Okay. I think it is kind of wonderful to participate in this or these two presentations. Well, I mean for the China side, I think without the presentation from Professor Wong, we don't know how much has been happening in China. Particularly China is such a big country. I'm for me, my work in the last few years related to China, mainly focusing on the Greater Bay Area. But then something that immediately inspired me thinking about tip card, strike, and then what Professor Wang has been doing is whether we can, for example, if we focus on the 9+2, cities in the Greater Bay Area, and then whether we can really do something to think about, how we can promote quality health, prevent dementia, and increase access, to care. And then another one that is also amazing from Professor Wang's presentation is the social prescription or prescribing, right? From psychiatry, because when we met psychiatry in Hong Kong, usually they will focus a lot on drug treatment or medical intervention. But we know that for dementia care, first one is most of dementia are in community. Second one is the support of informal caregiver is extremely important. Third one is actually if we can do more social prescription or, actually it may help to improve the quality of life, reduce the symptom, as well as, in longer term, hopefully also slow down, the progress of the disease. So I think there is a great potential that social sciences can really work with the medical sector, including both specialists like psychiatry, geriatric, or nurse, or OT, or PT, right, to really work out a system of social prescription. So this is number 3. And the last one I have been in mind is dementia care is more than just, professional care or care delivered by the paid staff. So whether we have a mechanism to empower and encourage the community, other than the family member, to be really involved, for example, in the social prescription. One thing that I have been talking when I'm in Hong Kong, in the Jiangguanhou area, is using the time bank system to kind of, it was a very recent discussion, because the way the Hong Kong government funds social services is paid services delivered by, in the community. So those are delivered by paid staff. So the government gave money to social services sector, and then they hire paid staff to deliver community care. But by doing so, a lot of time we need to bring the patient or the family, person living with dementia, to the center to receive services. But if we can mobilize a large number of volunteer, for example, when we're talking about behavioral activation, we don't need a PTOT to do behavioral activation. We can use a volunteer to do so. And a volunteer can bring the services, even one-to-one, like a Tai Chi exercise, to the family or to the building that the older people are living. So we are thinking whether we can really kind of reinvent the whole social services. Instead of government pay services to NGO, the government pay services to NGO, but to enable the community rather than to deliver the services. And then the delivery should be by the volunteer, maybe using a time credit system. And the second phase is once we can convert a recipient, like a family caregiver or a person living with dementia, from a recipient, for example, a person who participates in one-to-one exercise program or one to three or market game, right, to become a provider. That means he or she can really become a provider to the person living in the same building or same public housing estate. So he or she can earn time credit by doing so. So when he or she receives services, it is a debit to the time credit. But when he or she provides services, be a companion with another person with dementia, in a market game, so he become a provider. So I think there is a lot of potential if we think innovatively outside the box, that we can mobilize the community to be part of the solution for the coming population aging, dementia. That people like to use the term salami, but I think it is also opportunity for the community to really get involved. So let me stop here, but I think it is really exciting moment that we can think outside the box, combine the innovation or innovative mind of both medical science, nursing, PTOT, as well as social sciences, to really help the society to better prepare for population aging. Thank you so much.
So, Terry, so I think I totally agree with what you just mentioned about how to actually manage dementia in both professional as well as a more normal perspective. So I really enjoy the seminars presented by Dr. Wang and also Martin. So I think one of the things that really captures my attention is one-stop service, because I remember 2 or 3 years ago when I helped in launching the theory of change workshop, I actually learned from different stakeholders what they want to happen in 10 years time is we have one-stop service for dementia management. So this one-stop service will start from the community about early risk identification, preparing the community so as to make it more dementia friendly, and then you move to the diagnosis as well as the post-diagnostic care by the healthcare service, and then we expand to the social care support and caregiver support as well as the policy planning. So when I want difference, because we actually go for 2 or 3 workshops on one evening. So I heard from different practice in different workshops, what they want is really one-stop service. So I just learned from Dr. Wang in China. What is doing in China is to form a digital platform with a care coordination to bring together different stakeholders in order to do better management. So I would like to hear more about how to do it, because in Hong Kong, the situation in Hong Kong, when we're talking about health and social care, they are actually under different government sector. And then talking about within one single sectors, we do have boundary between different professionals. Say, for example, is it nurses is doing the coordinator or the PT or the OT? And then how did the doctors really access the information from the nurses? To a certain extent, they will use it. And talking about cross sectors, in Hong Kong, we have different database. The database managed by the hospital authority, and then we just have the primary care authority, and the government actually has the most recent policy address saying putting more resources to support primary care, and there would also be a database. But how to actually bring these 2 databases together and let the care coordinations to be more successful? So I really want to learn from the experience in China, talking about a very powerful digital platforms to facilitate care coordination, and also what has been done by the strike, and is there any insights to inform this development in Hong Kong?
Yeah, thank you. I think 2 very important points. So engaging the whole community, to mobilizing the whole community, and coordinated care across discipline. I want to see whether Huali and Martin has any response to that. And also for those of you who are joining us online and in person, if you have questions, feel free to put up your hand if you're joining in person, or if you are joining online, you can feel free to put into the chat box or the Q&A section. So let's see if Huali.
Hi, Gloria.
Hello.
Yeah, can you hear me?
Yes.
Okay. Yeah, thank you very much. I thank you very much for your kind comments on our presentations. And also, I would first like to share my reflections from Martin's presentation. Actually, I learned a lot from the project, the STRIDE project, because when they developed, try to implement the STRIDE project, it is a great experience that can integrate implementation research when they implement a service. So this gives me more ideas that when we try to improve the implementation of China Dementia Strategic Plan, we still need to strengthen the implementation research that can help us to accumulate more evidence, not only to explore the effectiveness of the interventions, but help us to explore the mechanism and also how we can operate such kind of services in the community. We need to accumulate a lot of scientific data. So this is, I think that I hope that after the meeting, we can keep more connection with Martin's group. And we can learn from STRIDE project. Also, we can also work with Gloria and your team to that we can share more experiences and trying to collaborate on implementation research from your tip card project. Actually, I recently wrote a perspective paper calling up for strengthening implementation research in West Pacific regional region to promote old adults' mental health, including not only like depression, anxiety, but also dementia. So I think that in a few weeks, this paper will be published online. It was just accepted. And then going back to your comments on our practice here in most of the region, most of areas in China. Actually, in the past 2 years, we have been trying to support more underrepresented area, not only Bay Area, because Bay Area is more well-developed. We worked with some of like the cities in northeastern area, the cities in western area, and also some of the middle part of China. They have very little resources to provide high quality of care for people living with dementia. But in the past 2 years, we not only focus on dementia, because we think that dementia is only one part of the old adults' mental health concerns. We need to help them to build the system. If the system is not ready, dementia is not so easy to be supported. So that's we help them to train. We suggest them to build the multidisciplinary team. Building our previous experiences, we share them that probably one team only need 1 to 2 mental health specialists and 2 to 3 social workers, and getting the community staff 1 or 2, the leaders of the community to be involved. And that's enough. And the community staff can help them to find volunteers from the community. For example, some of the old adults living in the community, they are happy to join, to act as volunteers, so they can mobilize their residence area. People can try to improve and participate in activities that social workers supported. So in that work, actually, we did a pilot study, And we found that the old adults living in the communities, they had a little bit lower performance in cognitive tests. But after 3 months participation in social workers activities, their general cognitive performance can be improved. And that reached to statistically significance. And interestingly, we found that their level of social service utilization is associated with the change of cognitive performance. So that supported or supplemented our hypothesis that having more social participation and trying to use more social service resources may help them to improve the outcome. So now that's why we try to get more communities to be involved, and then we will start a new study this year to figure out how the outcome will be. So that comes to the second question, is how we make this digital platform to be developed and the people can use it. Actually, the idea of developing a digital platform not only came from my idea, it came from the service providers. When we piloted social prescribing, the local service team asked, because we are the first team to be trained to perform social prescribing, we may not be capable of doing all the service that you suggested, and we may not coordinate efficiently. So they think that if there's some digital assistance that can help them to follow the protocol and to schedule the activities within the scheme, that can save their efforts and also can help them to improve their compliance to the protocol. And then we turn their request to the technical staff, ask them, is that possible? And then afterwards, this digital form was developed. The initial one was not perfect, but now more and more function has been introduced. And now Tencent has volunteered their efforts to help us to improve the friendliness of this platform. And the platform currently is not for the persons receiving services, it's for the person who provides services. So that so the users are easy to be trained, and the platform help them to follow the protocol. That can, to some extent, even the service provider are in lower capacity, but if they follow the protocol, they can try to make their services to be applied easily. So this is the work that we are doing. I think that when Tencent considered our platform is perfect, they will help us to promote this platform to more areas, because they have a high standard a high standard of the friendliness of digital platform. So although I think that it's very good enough, but they think that no, they are not perfect, they will try help us to improve it. So this is the resources that we are using. We consider that to promote old adults' health may start from promote the service leaders and the service providers. Then the old adults may build more confidence in local support, and then they will get access, try to use the resources according to their own needs. So that's my perspective. Thank you.
Thank you so much. Martin, do you have any very quick response?
Yeah, I mean, just three things quickly to say. One is, I think from what we've heard, that firstly, I mean, dementia is not merely a health policy. It has to be a whole of government policy. So it needs to be embedded in social care and housing and transport and urban design and digital technology and everything. So that's the first thing. Secondly, I think that we're hearing that dementia is not merely a patient and family issue, if I can use that term, but it's a whole of society responsibility. So again, I think it's broadening out that. And the third thing just to say is a plug, actually. So Gloria and I have just finished a paper for one of these STRIDE special issues, looking at the barriers, particularly the economic barriers to implementing these really good policy plans and these intentions. And there's lots of barriers to do. I mean, particularly quite often the investment is needed now, but the payoffs are not going to be seen for some years. The investment is needed in one sector, but the payoff, the benefits will be seen in a different sector. So that these sort of barriers emphasize this need for a whole of government response to the dementia challenge. And I'll stop there.
Great. Thank you so much. I think this is a very rich discussion, and it's totally in the interest of time. We have to cut this short, but I hope that we can continue the discussion after this. So thank you so much for our panelists. And may I introduce our next speaker, Dr. Jacky Choy, who is going to, Dr. Jacky Choy, our research assistant professor in the Department of Social Work and Social Administration. And the stage is yours.
Hi, everyone. So, wow, it has been a long while to have a face-to-face seminar in Hong Kong, actually. So, yeah, it's my great honor to be here today to talk about the dementia situation in Hong Kong. And it's also a huge pleasure speaking after Professor Knapp and Professor Wang. Okay, so I will try my very best. Okay, so okay, let me move on. So as Gloria introduced at the very beginning, so this part of this TIPCAP project, we try to assess the dementia situation in Hong Kong. So what we have been doing is that we did a in-depth situational analysis that comprised of a desk review and then a SWOT analysis, which means the strengths, weaknesses, opportunities, and threats of the dementia situation in Hong Kong. And we follow some tools developed by the Strike project team. Thanks again, Martin. And on the right-hand side, you see that actually the desk review, we have already published it online in our project website. So if you're interested in the very details of this boring document, you can have a look. But I promise you, boring. But it's actually a huge collective effort of our whole team. I've seen many family faces sitting here. So thanks, everyone. Okay, so when I start to prepare this presentation, I start to think, okay, so what we can offer in this global response seminar. So let me move on to the next slide. Does this look familiar to you guys? So I swear to God, I didn't look into Martin's slide. So this is what I'm trying to do. So after our situational analysis and SWOT analysis, I try to think about, okay, although Hong Kong is not a individual party in WHO global response on to dementia and the action plan, but I try to think about, so actually if we want to work according to this action plan, how is our current progress and status now? So I will skip the time to introduce these 7 actions area. Okay. So the first action area is actually dementia as a public health priority. And on the upper, okay, over here, you will see the orange text up here are actually the global target set by the WHO. They want the countries to have national policy, strategies, plan or framework for dementia, either is standalone or integrated into existing or other policy. So on the very first point I want to make is that in Hong Kong right now, we don't have a standalone or integrated policy or plan that is specific about dementia. Okay, although there are some policy documents like mental health review report and elderly service program plan in 2017, but those recommendations and framework didn't actually turn into implementations or actions about dementia care in Hong Kong. Unlike what Professor Wang shared in China, after they have some kind of policy document, they turn into actions very quickly, but that's not the case in Hong Kong. Yeah, and I start to look into the situation and think about, so what are the major barriers or weaknesses of our Hong Kong system that doesn't make these changes possible? One of the major weaknesses is about that we don't have a clear or widely recognized dementia-specific government unit or representative. Just like what Professor Doris you mentioned in the panel, in Hong Kong, we have the healthcare sector and the social care sector responsible for dementia care. So it seems that people is trying to rely on a single leader or representative for such policy change, but that's we don't have a very clear leader in this agenda. So for agenda setting or policy formulation, we have the Health Bureau, the Labor and Welfare Bureau, and we have the Mental Health Review Advisory Committee and Elderly Commission. So many different parties on the table, in the room. So who should we look for if we want to establish a dementia-specific policy? That's one big puzzle in the discussion. And but we also have certain strengths compared to other countries or regions. We have a very stable and recurrent healthcare and social care budget, and we have developed systems and infrastructure. But one threat that we are facing is that whether or not dementia is still a priority in the policy agenda, especially after we have changed our CE. Okay, so let's move on to the next action area, which is dementia awareness and friendliness. Okay, so one good news is that we have one dementia public awareness campaign. Okay, that is called a dementia friendly community campaign that was launched in 2019. I forget the exact year. It was a 3-year campaign. Okay, no matter you have heard of it or not, that is the campaign. Okay, but one of the objectives, this campaign is led by the Social Welfare Department, and one of the objectives is to have over 10,000 registered dementia friends, and they have achieved that objective already. But other than that, we know nothing about the impact of this campaign. Okay, but if we just to check against the WHO action plan, we did achieve this target. Okay, but other than that, the WHO also warned the countries to have a dementia-friendly initiative. So in this aspect, we didn't meet this target. And what it means by dementia-friendly initiative, DFI, it means that we have something like public spaces or building or community places which are made to be dementia friendly. So this is what they try to do. Okay, and but in terms of the overall attitude or stigma about dementia, well, from local studies, we see that our care workforce or volunteers or even some other sectors workers, they are having better and better attitude towards dementia. So this is one thing that we are strong in. Yeah, but unfortunately, we don't have up-to-date data about the public knowledge and attitude towards dementia. The last study in 2015. Okay, and next area is dementia risk reduction. So in the WHO target, they try to follow this target of the global action for prevention and control of non-communicable diseases. And these are the diseases that actually contribute to a lot of risk for dementia. And this is the situation in Hong Kong. I draw these statistics from the health survey of that conducted in Hong Kong, which is a kind of a territory-wide representative survey. And we look at different, quickly look at different roles. For alcohol, moving from 2014 to 2020, we actually achieved the target. Okay, for tobacco use, we also succeed, but for hypertension, insufficient physical activity, and diabetes, we actually did not meet the target of WHO. And even worse is that actually you can see, for example, like for hypertension, the self-reported rate actually increased during this 2 time point of data collection. Okay, and for obesities, we still don't have the updated figures because we're still waiting for the full release of the health survey findings. So these are something happening in Hong Kong. And one good thing, one of our strengths is that we do have this regular health survey that was conducting, I guess, every 5 years. Yeah. And in Hong Kong, there are also existing action plan that towards the non-communicable disease. Yeah. And although in this action plan, they did not spell out dementia, but is perfectly fine that because all these factors are actually largely the risk factors of dementia. And for the next areas is about dementia diagnosis, treatment, care, and support. In the WHO action plan, they emphasize on the diagnostic rates. Okay, but sadly in Hong Kong we have a up-to-date diagnostic rate at this moment. Okay, so I would say we fail on this target. The latest figure we have is back in 2005. The diagnostic rate in the community is only 11%. Okay, but in the WHO target, they try to have 50%. Okay, so this is one thing that we are lagging behind, I would say. But so but why makes our diagnosis so difficult? So for example, one of our weakness or one of the issue that we're seeing in Hong Kong is the long waiting time for diagnostic service in the public sector, that it may take around 1 to 2 years for someone who want to seek help from the public hospital doctors. Okay. And other than that, actually, we have anti-dementia medications available. Our care systems are quite developed, and we have trained secondary and tertiary dementia care workforce. So these are some strengths that we can continue to build on. And but one of the major threats is that we are facing the shortage in care workforce. You may notice that quite a lot of Hong Kong working class generation is moving out of Hong Kong, and at the same time, in the within the care services, the turnover are quite high, and at the same time, the public have heavy reliance on the public services. So these are some major threats to our care systems. The fifth area is about support for dementia carer. The global target is to provide support and training program for carers and families. For this one, I can confidently put a big take for the first point. So Hong Kong, we have readily available carer support service, including training and education, psychosocial support. And one of the major dementia service initiatives that is, I wrote here, DCSS, Dementia Community Support Scheme. It also cover carer support services. Okay, but here I put a tick here. It's only saying that these services are available. Okay, it doesn't mean that it perfectly fulfill the needs of the carer. Okay, and one of the weaknesses is about, for example, is about our respect service, which is not flexible enough and is not tailored to the needs of the family carers. So this is sometimes we can always see very low rates of utilization of the respect service, although the carers really want to take a break or they want to have respect. And another special characteristics about Hong Kong is that we have a huge kind of a relatively huge number of foreign domestic helper, and they were very involved in our day-to-day elderly care. And quite recently, the government's tried to train them for delivering elderly care. And this is one of the opportunity that we may leverage on if we want to strengthen dementia care in the informal care sector. And the sixth area is about the information system for dementia. And then again, the global target is that the countries should routinely collect a core set of dementia indicator and every 2 years. That's the global target. But unfortunately, in Hong Kong, we don't have a routine monitoring mechanism about these dementia indicator. We only did it like occasionally. The last time it was in 2005 through the thematic household survey, and the more recent one is actually started in was actually started in 2019, and the results are going to release very soon, which is the Hong Kong Mental Mobility Survey for older people. So we are actually looking forward to the findings of this survey. So we'll have more up-to-date figure about the prevalence of dementia in Hong Kong. And another strength is that we have some cost estimation about dementia cost, which my colleague, Dr. Shi, will share in her next section. Yeah. Okay. And some of the potentials, the opportunities that I want to bring up is about integrating different database of health and long-term care services, like what our panelists have shared. We have a database in the primary care, in the hospital authority, whether or not these database can be integrated or shared with more stakeholders is a key about building the information system for dementia. And the last area is dementia research and innovation. I guess the researchers will be very interested in this one. Okay, so the global target is to have the output of global research on dementia double between 2017 and 2025. We do not have very up-to-date record to tell you the situation of Hong Kong, but we did a quick scoping review back in 2019. I see my colleague Dr. Chai is sitting here. She's the one leading this scoping review. So at that time, we try to count the number of local dementia research output. And from 1991 to 2019, we have 285 research output. I don't know whether this is a lot to you or not a lot to you, but we do need to do some further study to see whether it is sufficient or not. Okay, but but one of the weakness is that we don't have a official research plan or dementia specific research funding in Hong Kong, unlike what Professor Wang shared in China. So this is something that we dementia researchers will very want to, we're looking forward to see in Hong Kong. Okay, so in the interest of time, I'll jump to my conclusion, very quick one. So you can see that among these 7 actions area, at least by WHO, Hong Kong didn't do very well. Okay, so I end here, but yeah, we will upload the slide into our project website later. So if you're interested, you can feel free to have a look. Yeah, thank you very much.
Thank you so much, Jacky, for the very succinct overview of Hong Kong situation. So last but not least, may I introduce our last speaker, Dr. Cheng. She's currently Research Assistant Professor at the School of Graduate Studies and Institute of Policy Studies at Lingnan University. So over to you.
Okay, thank you, Gloria.
Oh, okay.
Thank you. Okay, thank you, Gloria. Hi, I'm Cheng. So I used to be the postdoc fellow for the TIPCAR project. So I'm very honored to be the part of this fabulous project. I'm very glad to have this opportunity to share our TIPCAR course of dementia study. So in case I will be too excited to stop myself, so I prepare some tips for this TIPCAR presentation. Okay. So the TIPCAR course of dementia study will focus on the economic consequences of dementia in Hong Kong. We aim to estimate the impact of dementia on society in monetary terms. So apart from linkage some existing data sources, we also conducted a survey to fill current data gap. Okay. So first of all, let's have a look at the care resources for dementia in Hong Kong. Usually, persons living with dementia receive healthcare, social care, and informal care. Informal care here refers to care provided by families, relatives, neighbors, and friends. In this case, healthcare and social care that provided by care professionals and care workers can be categorized as formal care. In the healthcare, we have inpatient care, inpatient and outpatient service. Social care service can be divided by residential care and community care. And regarding the formal, informal care service, this can be categorized as service for the activity of daily living tasks, that is ADL, and the service for instrumental activities of daily living tasks, that is IADL, and also the service for the supervision. Supervision here means time spent for managing people living with dementia's behavioral symptoms or to prevent dangerous events. For example, we may also saw the news that some persons living with dementia, they wandered off. So those are all the elements we were considered in our course of dementia study. Okay, so based on our data linkage work, we found that there are some evidence gaps in terms of the cause of dementia in the community. So we conducted a survey with 750 diets of people living with dementia and their informates who are currently living in the community. So given the long waiting list for social care in Hong Kong, we also included 40 participants who are social care recipients and also 60% participants who are not social care recipients. Well, this slide shows our sample characteristics. I won't go to the details, but I want to point out most of our participants, they used the social healthcare service use in the past 3 months, no matter they are social care recipients or they are not social care recipients. Okay, and based on this service utilization data and the characteristics of the healthcare system, we included the government expenditure, out-of-pocket payment, and indirect cost in our cost of dementia study. And eventually we found the average monthly cost of the formal care for dementia in the community can be 7,000 more Hong Kong dollars. For the social care recipients, that amount can be 6,000 more Hong Kong dollars. Well, for the social care recipients, that amount can up to 10,000 Hong Kong dollars. Okay, so the message here could be, if you look at the healthcare cost for the social care recipients and the non-social care recipients, we see that the message here could be if the person could not use the timely social care services, they may use healthcare service to satisfy their need, which was supposed to be met by social care service. Okay. And then we further break down this cost by dementia severity. We can see that particularly among the persons with severe dementia, the total formal care cost between social care recipients and the non-social care recipients are comparable, as you can see here. But the formal care cost among the non-social care recipients were all for the social care cost. We know that healthcare resources in Hong Kong is limited, and the cost of training healthcare professionals, such as medical doctors and nurses, can be very expensive. So the evidence here reminds us part of the healthcare utilization could be replaced by social care service. And then let's move to the informal care cost part. So first of all, our evidence show that 62.6% participants have at least 2 informal caregivers, and 41% participants have more than 1 main informal carer. What does it mean? Normally, when we talk about informal caregiver, particularly in social welfare scheme or providing social support for informal caregiver, we refer to 1 informal caregivers for 1 dementia patient for granted. It means usually it's only 1 caregiver could be eligible for support or benefits in most cases. Okay. So this is because we assume each person only has 1 caregiver. However, providing care service, particularly for people with dementia, can be very exhausting. 1 caregiver is not enough. Okay. Meanwhile, we also found 31% of our participants reported they have a foreign domestic helper, as Jacky mentioned. This is it's quite special for Hong Kong. Foreign domestic helper are very important care resources for us. Okay. So now let's look at the daily hours of multiple informal caregivers by care task. For the ADL task, the average daily hours can be up to 4.2 hours, while for IADL task, that can be 5.8 hours. For supervision, that can be 6.6 hours. Here we need to clarify that some care hours can be overlapped because some care tasks need 2 and more caregivers simultaneously to complete the task. And if we calculate the time for the monthly care task, monthly care time of the multiple informal caregivers, that can up to 400 hours. And 40% of the informal care time is attributed to supervision. Okay. Although we actually didn't pay for this informal care, but it does mean the informal care is at no cost. So as the informal carers, they could use the care time to do something else, like doing a job or just enjoy their leisure time. So here we did a very conservative estimation. We suppose the value of informal care for ADL task equal to care provided by care worker. So that number is 90 Hong Kong dollars per hour. And suppose the value for IEDL task and supervision equal to minimum wage in Hong Kong. That is 37 Hong Kong dollars per hour. And please note that actually the real opportunity cost of informal care hour can be much higher. Then we calculate the average monthly care cost of multiple informal caregivers of dementia, which is 20,000 more Hong Kong dollars per month. And for the non-social care recipients, this care cost of the multiple informal care time can be 80,000 more. For the social care recipients, the care cost can be up to 22,000 Hong Kong dollars. And then we combine with the formal care cost. Then we have the number. The average monthly cost of dementia in the community is 28,000 more Hong Kong dollars. 72% of this money are for informal care, while 19% are for healthcare and 9% for social care. Okay. And this is the average monthly cost of dementia for the non-social care recipients, and this is for the social care recipients. So actually this number is even higher than the median wage in 2021 in Hong Kong. And from this cost distribution, you can notice that in the informal care is the major cost element for community dwelling people with dementia. And based on our new evidence and some existing data, we further calculate the cost of dementia in Hong Kong. So this is the results from a recent prevalence study. It shows that in 2021 in Hong Kong, there are 178,000 persons with dementia. And based on this number and the macro level model, we calculate the cost of dementia in Hong Kong in 2021 is 60.9 billion. That's quite a lot. Oh, well, if we disaggregate this cost by care settings, then we have the results in the community. The cost of dementia in Hong Kong in 2021 is 52.6 billion. This takes up 86% of total cost. Well, the residential care cost up to 8.3 billion, taking up 14%. And in the community, the cost for non-social care recipients, 97.8% of the cost are for the non-social care recipients. Well, it means that persons living with dementia and their family carers, they are taking most of the economic burden of dementia by themselves. Well, here is just a simple projection on the future cost of dementia in Hong Kong. So, well, let's imagine that if we can maintain current prevalence of dementia in Hong Kong in 2021, although we know it's very hard because the prevalence is continuously increasing. And if no additional resources will be given or allocated for dementia, what will happen? So based on Hong Kong population projections, here is the results. So in 2031, the total cost of dementia in Hong Kong will be 84 billion. Well, in 2041, that number will be 141 billion. Okay. Here is just some quick summaries. So dementia has a huge economic impact on people living with dementia and their family, the society as a whole in Hong Kong. As the population ages, the total cost of dementia will rise rapidly. And we found cost of dementia is largely borne by persons living with dementia and their families. So we need to give better support for people with dementia and their family carers, as well as sufficient health and social care services. These are quite essential to address the current and future challenges of dementia. We hope our economic evidence can help to engage the public and also encourage policymakers to allocate more resources for people living with dementia and their family caregivers, and invest in appropriate treatment, care, and support, and the preventive actions and research. This is the end of my presentation. Thank you very much for your time. I think we will further release some results or find our website. And here is my contact. Thank you very much.
Thank you so much, Dr. Cheng, and thank you so much, everyone, for staying with us for 2 hours nonstop. As you can see, actually, we do have too much to squeeze into a very packed period of time. I guess that's also the situation of dementia care policy. We do have an urgency to develop a proper policy for dementia. So may I suggest that we let's have a break. For those of you who are joining also the public talk, we will be starting soon. And for those of you who are joining the seminar, so we can use the break time to, if you have questions, grab our speakers in the coffee break area outside. So thank you so much, everyone. Yes, it's outside.